All right. Our next speaker is Dr. David Wang, who's going to talk about an age-old question for stroke neurologists, anticoagulation, which is still, to this day, remains controversial, interestingly. So the topic of his talk is stroke prevention, atrial fibrillation. Can we not anticoagulate? Dr. Wang is currently the co-director of Pesnick Stroke Center and also professor of neurology and interim director of the Stroke Fellowship Program at Barrow Neurologic Institute in Arizona, Phoenix, Arizona. He's also professor of neurology at the University of Arizona, Creighton University, and University of Illinois, Chicago Medical School. Before he joined the Barrow, he built the second in the nation Joint Commission certified comprehensive stroke center in Peoria, Illinois. He is the deputy director and general manager of the journal Stroke and Vascular Neurology with an impact factor of 5.9 and rising. That's the official English journal of the Chinese Stroke Association. Dr. Wang has conducted over 50 clinical trials in stroke in his career and published over 80 articles, which is very prolific. He's the chair of the stroke section of the American Academy of Neurology from 2017 and 2019, and chair of the AN Quality and Patient Safety Subcommittee from 2015 and 2018. He's also a graduate of the Michigan State University College of Medicine. He did his neurology residency at Henry Ford Hospital, Creighton University, and University of Nebraska. He was one of the last stroke fellows trained by the late Clark Millikan, the founder of American Stroke Association and Stroke Journal. Dr. Wang was voted the Faculty of the Year for teaching in 2017 at University of Illinois, Chicago School of Medicine, and the third-time recipient of Golden Apple Teaching Award, and also Physician Angel Award for Patients and Service Quality Stars by the medical staff while he was at the school. He's also the founding president of Chinese American Neurologic Association, and a close friend and colleague. Please welcome Dr. David Wang.
Thank you, Tony. That was quite an honor to be invited here to give this talk at this very prestigious symposium. Yes, this is has been a long time been to New York. I have to say, when I landed in JFK yesterday, it was quite emotional in a sense, because when I immigrated to the United States in 1982, that was the airport I came in. So this is the second time I landed in JFK. It's quite different now. So yes, thank you, Tony, for the introduction, and I think your introduction is longer than my talk, actually. But this interesting topic, yes, for some reason, I would just say that this atrial fibrillation and stroke prevention, it seems to be simple, but it seems to be more complicated now than we thought. Billy, I loaded 2 sets of slides. I actually uploaded one more last night. I want to have one more updated version of this. It says final, but maybe that's the version, but it's okay. But only additional 2 slides. So without wasting time, so let me get this thing started. It was so nice to have met my mentor, Dr. Stephen Levine, when I was a resident at Henry Ford last night. It was quite a special. So let's get started. Here's my disclosures. So as you all know, that atrial fibrillation is a quite common condition for stroke as a cause. And of all the strokes, about 20% are ischemic strokes are from atrial fibrillation. That's one side. But for hemorrhagic strokes, we all have to pay attention that about 20% of those hemorrhagic strokes may be associated with the utilization of anticoagulation in atrial fibrillation or in strokes. So to balance it out in terms of anticoagulate or not in atrial fibrillation is actually become controversial at times. So let's get this beginning to get started. As you know, this is how we do EKG many years ago. At least when I was a resident at Henry Ford, and we're still using the machine. Nowadays, it's quite sophisticated is how we capture them. However, the reason that we have learned atrial fibrillation would be a cause of a stroke came from the Framingham study. The Framingham studies have told us that indeed that it is a solely independent risk factor for ischemic stroke. So atrial fibrillation settled as one of the causes of ischemic strokes. As Annie just told us, when you divide it up based on the TOAST criteria, as you know, you all know what the TOAST criteria stands for, right? The TOAST criteria was actually coined by Harold Adams from University of Iowa when he finished the clinical trial of the learning of studying the heparinoid. Okay, as you know, you have a heparin, you have a low molecular weight heparin, then you have a heparinoid. So the molecule is the largest, the heparin, and then the second largest will be low molecular weight heparin, and the third one would be the heparinoid. So study of the heparinoid, testing of the organon, I think 30210 in acute ischemic stroke trial stands for TOAST. That's how you come with a stroke classification: large vessel disease, small vessel disease, cardiogenic emboli, unknown, and all those other reasons. So atrial fibrillation is now settled as a cause of ischemic stroke. And in fact, there are many people in the United States have this condition. Many have actually mentioned on the death certificate. So the people of European descent are more likely to have AFib than the African Americans. And these are the other common causes. So if we put them together, and we're going to talk about this topic in these probably 6 areas. So the first is the cause. Now, you all know that the cause of atrial fibrillation, number one, is advancing age. Older age will cause atrial fibrillation. So with the population become aging, this condition become common. Now, including both of my parents, now they're in the 90s, they all have atrial fibrillation. So I'm getting a little worried when I'm getting to that age, maybe I will have AFib. Hypertension, obesity, European descent, and also other risk factors here. So these are the risk factors you have learned. Now, what does the guidelines say for atrial fibrillation and stroke prevention? Because this is where we have been practicing for the past 10, 15 years. The stroke neurologists, internal medicine doctors, we're all using guidelines. The 2019 AHA, the guideline, ASA guideline says that if you calculate the risk of a stroke using the CHAS-2, VAS-2 scores, that's CHF, hypertension, aging, and diabetes or stroke. If you put them all together, if your score is greater than 2, or for female greater than 3, you have the higher risk of having stroke. The higher the CHAS-2 scores, the more likelihood you're going to have a stroke. So you need to do something about preventing these people from having strokes. So the guideline says, yes, and for those people, you would consider anticoagulants for stroke prevention. So before, warfarin was a choice. Now we have a DOACs, or you call them a NOACs, or you have dabigatran, rivaroxaban, apixaban, or indoxaban. So the thing is, we also learned that if somebody who cannot be anticoagulated, okay, there are many actual indications, people who cannot be anticoagulated, you may consider left atrial appendage closure. Now, we will have a discussion on this. Now, last night I have learned from Dr. Tony Wang at the Mammoth Hospital here that you guys are already working on heart-brain collaborations. This is one of the topics in terms of stroke prevention. Now, people say, well, why don't you just go ahead and do ablation and stop the AFib? So if you can get the rhythm to become regular, and then you don't have to anticoagulate with these people. Or to ablate atrium, either with cryo or with laser therapy, the purpose of that is actually to help with prevention of CHF. It is not helpful for preventing stroke. In those patients, you may still have to anticoagulate for stroke prevention. So CHF, ventricular functional loss, will be helpful if you have bad atrial fibrillation by the treatment of atrial ablation. But beyond that, stroke prevention, again, comes to anticoagulation. Now, the cutoff guideline for starting oral anticoagulants is different for European guidelines and American guidelines. European says you have one risk factor, you have this score of 1, you should consider that. For the United States says, no, we need about 2, all right? So it just tells us that the threshold to start oral anticoagulant is low if you have atrial fibrillation and considering that. So how do we monitor for atrial fibrillation? We have showed this number 2 slide that before we use a very clumsy 12-lead EKG, and then later on very clumsy the Holter monitoring system. But nowadays we have either the mobile cardiac outpatient monitoring unit, or so-called MCOT, or more sophisticated nowadays is this so-called implantable device monitoring, which is called loop monitor. I'm not sure at Maimonides here that is a neurologist or cardiologist implant the loops. Then our institution, I can implant the loop. Now the thing is, I've been cutting down my implanting of loops. I'll tell you why. So let's work on this concept a little bit. First of all, we need to talk about 2 pivotal trials about the long-term monitoring and capturing of atrial fibrillation, and what have we learned, right? We have this very sophisticated little USB drive type of thing inserted in your chest between the 4th and 5th rib. And then we can the things can stay there for 3 years. And how likelihood can we capture atrial fibrillation, okay, by implanting such a device in your chest like that? So this is called, what I have learned, it's called Crystal AF trial. Crystal AF trial. What they did is they randomized a patient with a history of cryptogenic stroke that Andy just talked about. It's like these people who stroke with potentially questionable, suspicious cardiogenic, but yet we don't know what they are, so we call them cryptogenic. But yet, as Andy defined, there are many other potential reasons, which cannot be only solely potentially attribute to cardiac reasons. But in these cryptogenic stroke patients, and regular monitoring versus the implantable cardiac monitoring. And so you can see that with the implantable cardiac monitoring, and if you stay there for 30 days, 3.7% you capture AFib. The longer you go, the chance to capture AFib is higher. If you, the 30-day were regular monitoring, you would do about 3% of capturing with MCOT or non-implantable device. So yes, indeed, we have learned that if you put an implantable cardiac monitoring device, the longer you stay there, the more likelihood you're going to capture AFib, okay? So then once you capture AFib, we also know that you will be more likely to be started on anticoagulation, right? That's what guideline says. But the notion I want to let people think about this is that during the 3-year follow-up, there are very few strokes recurred. Very, very few. I mean, if you would capture 30% more atrial fibrillation in those patients, they're not going on to have more strokes. Then you may say that, okay, could these people be on more of anticoagulation or not? But the thing is, it was a surprise to us that if you would capture more atrial fibrillation, you should, well, maybe going to have more strokes. But somehow the stroke rate was low in both the monitoring group, and that means you don't monitor for that long, capture as many, you don't have more strokes. And those strokes from this trials, unfortunately, we can't tell where they come from. And if you talk to the PIs, they said they more likely could be from small vessel disease rather than atrial fibrillation. So the notion is, okay, yes, we captured more AFib, and did they really have more strokes? Have they go on? So that's the trial. Now, the thing is, you can see that the primary endpoint is to capture AFib. Secondary endpoint is to capture AFib, and then recurrent stroke with TIAs. If you look at the first 6 months of people on ischemic stroke TIAs, and there are very few of them. So this is where the puzzling to us is that, oh yeah, we have a great success in capturing atrial fibrillation with the implantable cardiac monitoring device, somehow they're not going on to have more strokes. That was kind of something we need to learn more. Well, the second trial is stroke AFib trial. Now, this is you all very familiar with. Li Shuang has mentioned this, I think, last year at ISC in Dallas. Again, this is the group of patients they studied by using the implantable cardiac device in patients with large or small vessel disease. Now, this is becoming even more interesting because if you have a known 99% carotid stenosis, ipsilateral stroke, okay, you asked our IR people, including Dr. Wang here, to stent these people, and then you say, I'm done with this. But then they say, well, are you going to monitor these patients for AFib? Or are you going to define maybe potentially there's another cause? That's another question. Or those people with convincing lacunar stroke in the basal ganglia. From risk factors, small vessel disease, clear lacunar syndrome. Are you going to put them on ICM, implantable monitoring device for 3 years? Well, this study says yes. Well, if you put that device in there, again, you would have a higher chance and to capture more HFib. I said capture more AFib. Didn't say they are going to go on for more strokes. So the more the do, the longer you implant and stay there, the event rate will be captured more higher. You can see that up to 21%. Then the crystal AFib is about 30%. So now we have 2 trials from monitoring with the long-term implantable devices telling us we can capture more atrial fibrillation for sure. That is settled. Do those patients go on for strokes? We're not sure. Again, and if you can see this, okay, and then maybe in these patients that you can stratify and say, look, maybe these are the patients I should do more monitoring rather than everybody should go out of a hospital with their loop monitor in their chest. So among those with this CHF or left ventricular hypertrophy, maybe there are more HFib capture. So could this be the group? It's worthwhile to do this rather than everyone goes out to get one. So there's maybe a subgroup of this study is telling us which are the patients where you're going to go to implant a loop monitor. So if you look at this from the stroke recurrence point of view, from stroke AFib trial, okay, here's Andy talked about TOAST criteria. You would see the large vessel, small vessel patient monitored, controlled, non-monitored with ICM or implantable cardiac monitoring device. And if you look at their stroke events, you know, they're not really high, okay? They're not as impressive as we thought that with more AFibs capturing, they all go on and have strokes. So you can see that it's somewhere close between the monitored and the controls, and somewhere more bleeding than what happened in the potentially AFib patient who may go on be anticoagulated. So this tells us that rather than giving everybody a loop monitor discharge out of the hospital, and should we be more selective? So that is where I'm trying to come to. So okay, so each medical center may have to make that decision and on that. So what have I learned from these 2 studies? Well, the longer you monitor, yes, you'll capture more strokes, okay? Short monitoring may not capture AFib. If you monitor longer, you capture AFib, and they're more likely to go on to be anticoagulation. And we also say that from the stroke AFib trial, CHF left ventricular hypertrophy patient may have their higher rate of capturing AFib. Are they going to go on for stroke? About 5% or less, okay, or less. So we have this question, okay, duration of AFib, less than 60 minutes, or one-time AFib, greater than 60 minutes, or a few seconds of AFib. Do you anticoagulate all these patients? All right, so is that duration? Is that briefness, or brevity, or and long-lasting, or you capture when they have AFib 2 years down the road? Do you put these patients on anticoagulation? For example, as I mentioned, if this patient is convincingly a lacunar stroke, you put a monitor on the chest, put an implantable device in the chest for 3 years. At 24 months, you captured one bout of AFib, about 2 minutes. Are you going to put this patient 71 year on lifelong anticoagulation? Or you said enough is enough and dual antiplatelet therapy for 21 days, go on for mono. And if this patient, Dr. Tony wants to get into angioplasty stenting, successful, after that, dual antiplatelet therapies, and then you're going to put on a monitor, you captured AFib, maybe 20 minutes or less in 3 years. Are you going to be putting this patient on dual antiplatelet drugs plus lifelong anticoagulation? These are the questions that need to be answered. So what we have learned from some meta-analysis is that by doing the internal implantable cardiac monitoring devices such as loop, you really capture the AFib more, and you put these more people on the anticoagulation, but they're somehow, they did not really lower the stroke recurrence. So should we be more selective as to what are the subgroup of patients we should really focus on monitoring and treatment? So the next question is the significance of heavy atrial fibrillation before or after a stroke event, which is interesting that we may not know this before. That is, if a patient has a long-term atrial fibrillation going on, boom, have a stroke, and this is called known AFib, okay? But then patient has nothing. You had a stroke, you put them on the monitoring, you capture the stroke. It's called a stroke after stroke, atrial fibrillation after stroke, AFDAS, atrial fibrillation detected after stroke. So AFDAS and known AFib, are they the same? So we know that if you look at this chart, that how many people have atrial fibrillation worldwide, you would know that the AFDAS is about 20% of those patients will capture the stroke after, AFib after they have had the stroke, while the other ones are already having a stroke, having atrial fibrillation and go on, have a stroke. So what that means that if you have an atrial fibrillation, yes, you're more likely to have a stroke, and then more likely to be a severe stroke and very disabled and troublesome. So yes, this is what we mentioned that before. But the thing is, what we also learned that if you have a stroke, you capture them after the stroke, the atrial fibrillation, AFDAS, then the risk is a little different. And more likely if the stroke is happening to the insular cortex, and it would be like have the bad ejection fraction are the ones that are more prone to have a stroke and then develop AFib, rather than the common risk factors that we all know will cause AFib routinely or the aging population. So maybe there's stratification as to the risks once you capture stroke, atrial fibrillation after stroke or before stroke, could that be different? So this is where that the AFDAS versus TIA were telling us that, okay, known AFib after stroke, and it's totally not the same in terms of the risk factors having on the stroke. So this is probably different. If you look at this, we also learned that if you have an atrial fibrillation that has a longer duration, the risk of stroke will go high. While you have really short duration, all right, the risk is probably not that high. So we're trying to answer these questions. Known AFib, AFib after stroke, AFib with short duration, AFib very long. Are these messages from these studies telling us, should we put every patient on anticoagulation for stroke prevention once you find AFib? So it's something now become a little more complicated. We also learned that if it's a self-limiting atrial fibrillation, that the risk is probably not as high as those patients who have continued AFib but non-converted. So self-limiting AFibs and 24-hour or less AFibs, maybe the risk of strokes is slightly lower, and that's something to be thought about and to be considered, and that is where we are with that. So you have learned this from Dr. Sposado from the University of Southwestern Ontario. You know, that study is saying, look, there's a difference in the EKG versus prolonged cardiac monitoring to detect atrial fibrillation. That is, okay, is it possible that if we have learned that with all these new technologies capturing AFib, including your iWatch, Are they really meaningful? Or should we say, okay, if the atrial fibrillation was detected during the hospitalization for that index stroke is actually more harmful. So if you have EKG detected versus the long-term monitoring detected atrial fibrillation in terms of patient distribution here, that you can see that what is the difference in qualified event for these people to go in there to be randomized to the monitoring devices. So EKG and the prolonged monitoring unit in the delimit AFib stroke study, and you can see the distribution is pretty much the same, not much difference. So now we realize that for those patients who have EKG detected atrial fibrillation during the hospitalization, their cumulative incidence of strokes is higher than actually prolonged. So there's a difference in percentage rate in prolonged monitoring unit captured AFib go on have a stroke versus you're going to capture the stroke AFib right during your 7 days of stay. So this would tell us, yes, maybe it's more worthwhile that your monitoring unit, while the patient staying in the hospital for the treatment, is more meaningful if you capture the stroke that required your attention for treatment, either anticoagulation or otherwise. That's one knowledge. So what we learned from this so far, okay, the more long-term you monitor, you can capture more AFib, go on AFib, you capture, you go on more anticoagulation, but they may not always go on have a stroke. We also learned that AFib that is less longer a day is more harmful or riskier than maybe potentially self-limiting or short-lasting atrial fibrillations. So these are the data we so far have. So therefore, the guideline says if you capture AFib, CHAS2, VAS2 greater than 2, you should anticoagulate. Should we reconsider or be more careful to be more selective? So that is the knowledge we have. The other part of this paradigm is that there are many intracerebral hemorrhages associated with using of anticoagulation. This is not actually something that should be ignored. And Annie gave a talk about an hour ago. She has some concerns about, those ESIS patient, embolic stroke of unknown source. And you know the 3 trials of anticoagulation failed. Maybe there's a reason that everybody to go on anticoagulation is not totally always benign. So atrial fibrillation and associated with anticoagulation, they have many hemorrhages, and they actually not very benign. How do I prove this? Well, if you look at all the previous studies that prove that NOACs, okay, that rivaroxaban and dabigatran and apixaban and edoxaban, and these are the studies that use new oral anticoagulation drugs versus the warfarin. And what's interesting about these studies is that these are the patients who we did not include the patient has a past history of any kind of intracerebral hemorrhage or any high known bleeding risks. What are the high known bleeding risks? For neurologists, we know where they are, right? MRI evidence of amyloid angiopathy, superficial siderosis, previous stroke, hypertension, black spots on your GRE sequence. So these are very clean slate of patients who did a study and go on to have the comparison. So have these pivotal trials get these 3-4 drugs approved for AFib stroke prevention. But we also learned that if you're comparing the hemorrhagic rates of the oral anticoagulations, okay, so apixaban versus warfarin, edoxaban 2 doses versus warfarin, dabigatran versus warfarin 2 doses, rivaroxaban versus warfarin. And if you look at this, okay, the major bleeding events, it's not a few. You think that your apixaban is like cause no bleeding, and that is not true. I'm not sure this is how this is being perceived, that yes, you may have less than warfarin, but it's not actually that few less. Okay, this is the emphasis I want to show you, that your new drugs do cause hemorrhage compared with warfarin. It's not like you have 0 hemorrhage if you put them on DOACs or NOACs. They have a lot of hemorrhages. So this is in the trials. This is not something should be ignored. I'm not sure we actually pay attention to this. They say, oh yeah, 80-year-old, if apixaban 5 milligram BID, go home. Well, is that simple? Okay. Do you need to see any of the stroke neurologists to do a risk factor stratification before you call that shot. So we also know that if you look at the failure of the anticoagulations with DOACs or warfarin, the event rate per 1,000 patient per year treated, you would still have a recurrent venous thrombotic event about this event rate. But if you look at the hospitalization for hemorrhage, okay, I mean, the other ones are not that much better than warfarin. And if you look at all-cause death from strokes and bleeding events, and they are not much better than warfarin. So yes, DOACs and NOACs are not as safe as you may think. So you need to still using them judiciously. So compare the rate of mortality of ICHs between DOACs and warfarin, and if you look at these trials, you all learn that. So mortality associated with warfarin ICH, 35%. The bigger trend, 37%. 50%, 48%. So if you bleed from DOAC, you may be as well as lethal as warfarin. So not to ignore these data, folks, not to ignore these data. So we've learned that, and therefore anticoagulation is not always safe. So how do we stratify them? This is where Dr. Sartanto come to play. That is, you need to stratify the risk. We also learned that who are the ones are intracerebral hemorrhage free versus ICH. These are the ones. Superficial siderosis on the MRI, cerebral microbleeds, and small vessel disease or hemorrhagic transformation, hypertensive events, and cerebral amyloid angiopathy. So from this slide, for those neurologists want to start anybody on anticoagulation, you should always get an MRI. I mean, always, as a screening tool, okay? Always get your GRE sequence or SWI. SWI is actually better potentially. So these are the risk factors we need to pay attention to about that. And you can see that if you have a cerebral microbleeds, your odds of go up, have a stroke, bleeding, and associated with DOACs is much higher. And if you have another stroke, conversion to a bleeding is higher. If you have superficial siderosis, it's even much higher. So comparing with the smoking or diabetes, rate of potentially having a hemorrhagic stroke is lower. So you can tell that these are not ignorable risk factors that require your stroke neurologist to screen before you start anticoagulation. All right, so this is one thing to think about that. So we also know that DOACs do fail. They're not always successful. It's like you send a patient home on Pixaban 5 mg BID, which is the predominant DOAC being used in the United States, then you can see that they still having chance to have another stroke, and comparing with the warfarin actually. So, which is very interesting. That is this something that we should further stratify for a study to see if actually DOACs is always be all end all treatment for stroke prevention, and that is something we should pay attention to. And there's one slide here that I put on yesterday, but it did not get here, is that the new study from in JAMA from Manabel on diltiazem for heart rate control and interaction with DOACs is showing diltiazem, if you use more than 120 milligrams a day, the chance of bleeding is much, much higher if you're on DOAC. So that makes us start wonder that your trial will control the rhythm, and you put them on DOAC, and these patients are going to have intracerebral bleed. So these are the risks of having another stroke despite oral anticoagulation. So that comes to this conclusion that yes, guideline says AFib anticoagulate, CHAS-2 score greater than 2. Yes. We also learned that long-term monitoring capture more AFib. Yes. Do you want to start anticoagulation? We need to think about it. We also know that long AFib more riskier. We also learned that AFib with the anticoagulation can cause bleeding, including DOACs and NOACs. We also know that anticoagulation in AFib can also fail and have recurrent strokes. So what do we do? So what are the options? So we also learned that, you see, as Dr. Tony Wang asked a question about the atrial enlargement or atrial morphological change in AFib, they should be more likely to be anticoagulated. But in atrial fibrillation, we have learned that the culprit is the left atrial appendages. There are different morphologies of left atrial appendages, okay, different kinds, windsock, cactus type, and chicken wing type. So we have learned that this is actually the culprit. So this is not something new, okay? So we have also learned that if you shut this off, well, whoever had a reason to go for open heart surgery, and these patients either need a CABG or a valve replacement, these patients that we go on just resect and suture off the left atrial appendages. And look at this. When you do that, the left atrial resection patient stroke recurrence rate is much lower than people who did not have a resected. We learned that if you close off left atrial appendage, you can successfully prevent atrial fibrillation and related stroke prevention as the strokes. The left atrial appendage closure is not a new concept. It's actually started almost already 18 years ago with 3 different generations of closing devices now. And so they have been studied first against the anticoagulation, AFib, stroke prevention. And nowadays, we're trying to see if we have more indications for this therapy. You can see that these are the pivotal trials from Protect AF, Prevail AF, and these other trials that has taught us that by doing so, now you know that when you do the left atrial appendage closure, you need to do a septal puncture and put the wire through, and then you can close that. So these are the pivotal trials. And what have we learned? And this is the 2nd generation Watchman or Watchman Pro and Deluxe. And what we learned is that if you look at the meta-analysis of Prevail Protect trial, that the device closures is much more unfavorable versus warfarin in stroke prevention and certainly developing any kind of hemorrhage. We have a large amount of data. Again, this is not like a few little studies. We have the PROC trial, we have the Prevail trial, the Protect AF trial. All these trials have taught us that closing left atrial appendages is actually safe and effective. Well, where are the data? Well, if you look at this chart, if this patient has atrial fibrillation go on without anticoagulation or any kind of treatment of stroke prevention, they go on and have a stroke. If you put them on anticoagulations, okay, then they will lower their stroke rate with this red line. If you close their PLAA, if you close their left atrial appendages, they actually perform better potentially or equivalent to the anticoagulation in lowering even more rate of potentially strokes. So do not underestimate this treatment. That is to shut closed left atrial appendages. And so this is where that we have learned that yes, there is the effective treatment. It's been there for nearly almost 20 years. We have more studies coming to tell us about this treatment options. And you can see that the atrial fibrillation patient currently potentially go on for Watchman occluder of left atrial appendages these are the ones. There's a history of bleeding and then falling risk in the elderly patient, potentially cerebral amyloid angiopathy, and a high-risk population that cannot be anticoagulated or cannot tolerate any anticoagulants or allergic to. And then somebody just said, I don't want to take it. And you think about it, if you maybe in your clinic, there's a 51-year-old gentleman who's very active, had a TIA, you monitored the guy for AFib, you captured AFib actually in 3 months. You said, aha, you go on for anticoagulation for life. A 51-year-old man go on anticoagulation for life. Is that a way of treating that for stroke prevention? So we also learned that once you put a occluder in there, you don't have to go on long-term anticoagulation. In fact, you don't have to actually anticoagulate at all. You can simply go for DOACs, not DOACs, DAPT, okay, treatment dual antiplatelet therapy for 12 weeks and then go on aspirin, enough to prevent potentially device-related thrombosis. And Watchman amulet, and this is a plug plus a cap. So this is coming to be very helpful because there are many patients in the hospital or having a procedure, have AFib, and you want to stop the anticoagulation to do more procedures, you start wonder, okay, that AFib, would that cause stroke? What am I going to do with this patient? And you worry about when stopping the anticoagulation, they're going to have a stroke. So what we do is that we start occlude the left atrial appendage during the hospital stay, during the hospitalization, and hopefully before discharge. It's all good for the patient, and we discharge them all on depth without any further anticoagulation. It's all working out fine. The only thing that is not working out fine is that the hospital people don't like it because of financial reasons. That is DRG being lumped into that. So it's better financially if you do the outpatient, but the thing, there are people who may need it. Otherwise, it's difficult to do it as outpatient. So that is so far the indications and what's happening. And you can see that there are a few areas in terms of left atrial appendage closure versus atrial fibrillation prevention that there's some advantages. So first of all, if you occlude that, you may potentially have you don't have to be on anticoagulants. 2 is the severity of stroke may be reduced. 3 is that the atrial fibrillation stroke definitely is lower, and then no need of anticoagulation. So you can see it's pretty safe with these trials, that there's no trouble with the failure, or occluder is pretty complete, and then there's no truly thrombosis on top of the device, and so safety is proven. We also know that if you compare to the anticoagulation, that you can see that in many ways that it's favor the closure. And otherwise you have to put these patients on lifelong anticoagulation. Is that a problem? Is that a problem with the compliance? Is that a problem with that patient's lifestyle? I have to say that I think I'm not sure I told Tony before. My father, at the age of 89, I occluded his LAA with an amulet, and he's still now actively playing pickleball without needing to be fully anticoagulated. So that's what we're doing in Arizona, playing pickleball, just to let you know. So doing so far so good. No need of anticoagulation long term. If you look at a Japanese study saying that once you do the anticoagulation with stroke prevention, the stroke be less in size, less in severity, and then if you occlude them, this is anticoagulation benefit versus VKA in terms of stroke severity, then you can see that if you occlude them, it's actually better than even anticoagulation in terms of the benefit of less stroke, less severity, and less mortality. So therefore, we have options. Okay? So this is where we can say that, yes, we even lower the intracerebral hemorrhage rate and low ischemic stroke by doing the occluding. It's because, why? It's because these people are on anticoagulation, they just don't go on, have a falling episode, they start hemorrhaging. While you are not anticoagulating this patient with AFib with a closure of LAA, then they when they fall, they may be unlikely to have a hemorrhagic event. So this is where we are with that. So you can see that based on all the studies, we not only effectively lower the atrial fibrillation-related stroke by occlusion of the left atrial appendage, we also learned that they lower the size of stroke, severity of stroke, and mortality. Don't have to further pondering on that, and you can see that such comparison in the studies from the past 15 years have stand. So we come to the conclusion of today's talk is that yes, AFib is a known risk factor for stroke situated, and it is, if it's you captured after the stroke with your routine monitoring during the hospitalization, maybe that risk is higher. And if you captured later on, and yes, and then that become a challenge. You're going to go on really anticoagulate these patients or not. We also know that after today's lecture that both the anticoagulation and the closure are effective. But however, there's one benefit of closure now is you do not have to put them on anticoagulation anymore. So therefore, for those people who really cannot be anticoagulated, this is the only way of preventing stroke in atrial fibrillation is to close that left atrial appendages. Okay. I would always recommend an MRI to rule out potentially any hemorrhagic spots or risk of potentially converting into a hemorrhage potentially after anticoagulation or before anticoagulation to look for those signs of either amyloid angiopathy, superficial sclerosis, hypertensive bleeding, microhemorrhages, and stuff like that. So to answer that question from the beginning, can we not anticoagulate? Well, maybe the answer is we should stratify the risk, and maybe low risk and very compliant patient, easy to do, yes. And then should they go on lifelong? Now that is still controversial in a sense. So the higher risk people with potentially bleeding, then anticoagulation is not a choice. And then for those who cannot be anticoagulated, you may consider left atrial appendage closure as the first choice. Thank you all.
Great talks. It's getting more and more complicated. The more we learn, the more we have questions. Anybody in the audience has any questions? Doctor, we'll go give someone else chance first. Dr. Agarwal.
Thank you, Dr. Wang, for the excellent talk. It did give us an insight into something which, we stroke neurologists sort of may oversee, because we like giving anticoagulants. But a few questions, I know you mentioned at Barrow, you as a neurologist are implanting loops. Who monitors these loops? Is it you who's monitoring them, or is it the cardiologists?
Good question. We team up with the Wang cardiology group. Every implant goes out to be followed by all patients within 2 weeks to set up the monitoring, and they will be followed by the cardiologist.
Got it. Okay. Just again, because of logistical reasons, I was told, because this is something, I tried to do, and I was told by cardiologists, because of the financial incentive, the person reading it, he wants to do the procedure itself. Did you face any difficult time with the cardiologists, how to get it done?
Right. So what happens is the patient on the stroke service, as you do, we have primary stroke services. Those patients, you feel like you should implant one. We are the ones doing that, but when you do the implant, the device company should be with you to make sure that patients follow adequately and then turn on in terms of monitoring device. So that follow-up is well settled, situated, scheduled with the cardiology group you're working with. So yes, you require a cardiology group to do the subsequent monitoring and reading. And I'm not sure in the nation any neurologist can do that. Before I was trying to be the one doing that, but the thing is, it's very tasking. It's not doable, even though a computer can read all the arrhythmias. But you need a group of people to do that. So hence, it's not doable in a sense by the stroke neurologists to be the readers. So it's better to have a teamed up with a cardiology group.
Got it. Perfect. No, thank you so much. The second question was, anticoagulation, I know, so a lot of times, I think this is picked up by cardiologists or PCP, patients are getting EKGs or maybe Holter monitoring as an outpatient, and they're started on anticoagulation. Usually they don't get any MRIs. And I think you bring up a very good point about getting MRI with GRE or SWI sequence to look for amyloids or superficial siderosis. Should we be telling our colleagues to maybe even get it because of the risk of hemorrhage?
Yes, that's what has been my practice, and also our collaborating cardiologists. They would send to us to do the screening. If we see that, we stratify the risk. We potentially recommend not an anticoagulate, potentially for closure, or we say, yes, it would be safe to go for anticoagulation. So I would do an MRI unless there's a contraindication.
And in your practice, is there a threshold you have, any number of microbleeds, the degree of superficial siderosis that would make you not feel safe to anticoagulate the patient?
There's no subtle numbers of these black spots you can see on GRE and the nature of that, because sometimes if the singular black shadow on the GRE and it's sizable, that's potentially riskier. So very difficult to say, is there a number, because pertaining to the number-wise, maybe that is about amyloid angiopathy. As you know, in the guidelines, it says if you have more than 10 of these potentially CAAs, you should not TPA these patients. So that's kind of one thing said in that regard. But in terms of superficial siderosis, hypertensive bleed, and other these hemorrhagic risks, we don't have a set number. So it is truly something need to be studied.
Got it. And one other question, I know you mentioned about left atrial appendage closure, but this is like practically, I feel one of the hindrances. Like if I have a patient who has a history of is on anticoagulation, comes in with a hypertensive bleed. Now I am scared to put him back on anticoagulation. I send that patient for left atrial appendage closure. But even after a left atrial appendage closure, because of the paradigms, like either they require 12 weeks of DAPT or 6 weeks of AC and 6 weeks of DAPT, I mean, we're still putting them at a risk. How, or like, is there a period after their index hemorrhage you feel safe to transiently put them on?
This is a controversial topic because what happened here is that you need to balance out, is there such a risk by, because they're already hemorrhaged, you probably cannot anticoagulate anyway. So there's certain risk of potentially recurrent strokes already happening if you don't do something if the patient still in atrial fibrillation. So as you know, in these patients, we do not anticoagulate for 6 weeks anymore. They go straight on DAPT, 12 weeks. So if we feel that these patients with, bad ventricles, ventricular hypertension, having quite a few strokes on MRI, you cannot stop anticoagulation and then have a hemorrhagic transformation. We go closure during the hospitalization if we can. We'll hopefully get it done and then go on DAPT and forever. So without anticoagulation anymore.
Well, great. So before I got to Eric and also Dr. Liu, there's a question online by Maria. What would you recommend for to handle a specific case, someone who had AFib on during anticoagulation, DOAC, and also stroke, LA closure, no leakage, but still have recurrent stroke? Similar to what Dr. Agrawal asked, someone had recurrent beyond just the left atrial appendage, there's other causes in the AFib-related stroke.
Right.
How do you handle?
In this case, on this one, in terms of online, you kind of run out of a lot of choices because you can see there's no thrombus on the device. There's no leakage, which is a good closure. And then in that case, you may have to reconsider anticoagulation because it's not 100% successful in terms of preventing all AFib-related strokes. It's either it's non-inferior or maybe slightly better than anticoagulation.
Great, thank you. Dr. Liu.
Yes, sir.
Hello, yeah, Bing Lu from Maimonides. I'm a primary care physician. Thank you for the wonderful, review. My question is for the topic you didn't mention, but you probably implied on the atrial appendage treatment. We see more and more patients, chronic AFib patients, who may have lacuna infarct treated by ablations, successful cardiac ablation. In AFib, on follow-up is pretty much negligible. What would you do for the anticoagulation for these patients?
This is an interesting topic. After you have AFib ablation to try to correct the rhythm, maybe the rhythm is corrected, I would say that these patients probably should go on for an implantable cardiac monitoring device because I'm not sure those AFib are totally stopped, even though routinely by the check they are. But I have a feeling they do have transient AFibs. So I would go for an implantable cardiac monitoring device for those patients who have successfully had ablation treatment.
I see. So based on that finding, you decide whether to anticoagulate or not.
That's exactly right.
I see. Thank you.
Gary Friedman from Brookdale Hospital. One of your slides indicated that there were large and small vessel occlusions. Does this indicate, I mean, usually it was straightforward, small vessel occlusion were non-embolic, large vessel were embolic, but does this seem to indicate that if you find a lacume in the face of atrial fibrillation, is the atrial fibrillation implicated in the origin of that particular stroke?
That's in the stroke AFib study did not tell us. And that's exactly right. Is that a contributable cause or is it actually incidental finding? We're not sure. they just captured more strokes in large vessel and lacunar strokes or small vessel strokes with the implantable device. Do they actually, are these captured events responsible for those strokes are unclear? So we don't know. So this is where we need to study more. And therefore, that's why it's where it's just like my question is that, okay, pretty clear, but then you somehow picked up the AFib. What are you going to do with this? So yeah, something we need to continue to study. Good.
And it's kind of almost the same question as Dr. Liu had. Patient of mine had atrial fibrillation, underwent 2 ablations. His loop recorder had already died. And the cardiologist recommended that he stay on the apixaban because he just could not be sure, whether or not he would, totally stay in sinus. But it's been about 2-3 years. All the EKGs have been normal. What is your take on it? If you could comment a little bit more, please.
If in those patients, your implantable device or your loop device did not capture AFib, maybe they can be okay managed by antiplatelet drugs for stroke prevention without anticoagulation. But it is something you can see that even cardiologists are unsure, even though they say, okay, I did a good ablation and rhythms control, but somehow I'm not quite sure when they're going to flip into a little bit of AFib here. That's just something we just don't know. Huh? It's a judgment call, exactly. Yeah.
Great. I have a couple questions if I have time. I think 12 minutes. So sounds like, it looks like the left atrial appendage clipping or a closure is as effective, if not more, than anticoagulation.
It's probably at least non-inferior. That's
Right.
proven.
So would that be, in the future, be considered as a first-line treatment?
There are,
Considering the long-term consequences of hemorrhage and cost and all the other things associated with anticoagulation, non-compliance. So, will that be something that's a first-line treatment?
I think by next year, we should have some answers. I think there are 3 trials studying that should the left atrial appendage closure as a primary choice in AFib prevention, rather than have to be considering those patients who failed anticoagulation. So
That'll be wonderful, I think. It's a procedure that's in the skilled surgeon's hands, like what we have at Maimonides. That's well done, and we don't have a lot of complications, and we don't have long-term
easy to
consequences.
do.
Yeah.
Yes.
Yes.
Better devices now, actually.
Exactly. One kind of consideration that keep coming up in especially elderly patients with AFib is the fall risks in the primary care and also in our population with stroke population. What is your threshold for diverting this patient for procedure as opposed to anticoagulation? How do you gauge the fall risk? Some people say, the study says you have to fall every other day to justify not to be on anticoagulation in the past. But we often say one big fall could be end of the story. So how do you, in your practice, gauge the threshold assessing elderly's fall risks for anticoagulation?
So you mean the patient who have AFib that require procedure is what you're saying?
Require anticoagulation,
Yeah.
but they have a high risk of falling. Where's your threshold for?
So the definition of falling is again something depends on your individual assessment, and there are people who are almost falling daily is definitely at risk. But when they fall one time a month, that is something we're not sure is at a higher risk as the other ones. But the thing is, when falling potentially can be risky to cause a hematoma. So that is something, the quantity of the falling episodes, will that dictate our way of should we anticoagulate or not, is something not studied and we just can't tell. But I would say that based on your individual assessment of that patient and their home environment, is this truly a rather good family, good supportive system? Maybe you can be safe to continue the anticoagulation. But not to treat is not a choice because AFib will go on and give a stroke. So, but for me, I'm nowadays more inclined to close their atrial appendages. So I don't have to worry about anticoagulation once for good.
Great. Thank you so much, David. Any other questions? No? Go ahead.
So thank you so much. As a follow-up to that question, just a comment, it's a ton of goals of care discussions, right? Every day, this is what I talk about with my team. When there's a lack of data supporting one strongly over the other, it's a complete goals of care discussion with the patient and the family. So just to remind everyone, there's clinical equipoise here, right? So here's where one day I might ask you, what would you do?
Right.
Me, rather. And then 2 weeks later, I might say, you know what? Let's do it the other way around, right? Because it does make us a little bit uncomfortable to make these decisions. And it's our job to give the patient our firm recommendation for sure, but there are gray areas where goals of care have to be emphasized.
Totally agree.
And especially for the trainees.
Yes, we also have new trials come out with new data. Again, reshape our way of practice. This is true. Thank you all.
Thank you.